Yes, we do.
Yeah. So welcome back. And so I'm now joined by Anita, who you have seen maybe earlier. So Anita is going to speak about leukemia in, well, ALL in children. She's from Childhood Cancer Europe, and most probably she's going to introduce herself. So really looking forward to your talk.
Thank you so much, Samantha. I'm very, very pleased that I can talk to the audience of adult ALL patients community. It's our first time, and we have, I think, I would say 1.5 years ago, we started a relationship together with Alan to learn from each other, to listen more to each other. What does it mean to have leukemia in children or in teenager age or in adult? There are differences, as you all know. And before I start to go into the detail, what I did is to present you a little bit about CCI, as a Childhood Cancer International Europe. A little bit, it's only 5 minutes that you understand how we are, who we are, how we work. And because of leukemia is the most common cancer in children, that's why it's also very important for us to focus on this diagnosis, very specific. Even there is not a real patient group focusing on ALL only. So that's why we are very happy to cooperate as much as possible with Alan to look to the future. This is about us, and I go to the second slide. Childhood Cancer International Europe is a very, very new organization. It's a worldwide organization, but we are a legal branch in Europe since the end of last week. It's one of the largest umbrella and 66 member organizations we have in 33 different countries in Europe. So we cover almost all countries. And what we try that we have a very lively relationship with our national members to integrate them in our work, what we do, what will you see a little bit later. Only to introduce you, the faces are always interesting. I'm chairing this whole committee for the legal branch in Europe. And beside Anna and myself, we are patient advocates. My former profession is a pediatric nurse, actually, before I joined 20 years ago as a CEO for a parents organization. But all others are parents or survivors, childhood cancer survivors. These young people here, you can see, these are all childhood cancer survivors. I don't think any one of these had ALL, no, but one of these will join us very soon as survivors. And this makes us very specific that it is CCI Europe, when we talk about this, it's always parents and survivors. So we try to represent, and this is very new. It was always a parents organization in the past, but now it's parents and survivors. This is our little staff, I would say. So this is only very part-time, a project manager. Hannah is an ALL patient. She's a psychologist, ALL patient in her, I think she was 12. And this is our very nice guy from a policy manager, but only 1 day a week. But she's the only full-time manager in the office where I am now. So that's why all others, what you have seen, are volunteers like myself. Only that you get an idea about these projects and companies and the industry and other stakeholders where we are involved in, means in many EU projects where we get money for, that we are patient representatives in research projects. So this, or the worldwide organizations like WHO, we have a very good cooperation. They also focus on childhood cancer in the next years, what makes us very happy, but not specific in Europe. Europe, they look on Ukraine. Of course, they look really to countries where there are the most needs economical wise. So this one is very important for us because we are privileged in childhood cancer, I would say. We work very closely with the with the healthcare professionals, let's say the nurses, the academia, as the doctors, the researchers, and all those doctors, they are focusing on long-term follow-up care. This is this community, they only focus on long-term follow-up care, but because this is so important, if you have childhood cancer, leukemia, whatever you have, looking for long-term follow-up care, you will hear a little bit later that this is a specific area, what was forgotten for many, many years. And this is already my last slide about CCI Europe, that you see our strategic plan. We have areas what we are focusing on. It's, of course, research and innovation. It's diagnosis, treatment, and care. It's psychosocial care. It's very important for us as patient, parents, community, because many of these children are very, very young, like in acute leukemia. They're so young that they don't even remember when they get cancer. So it has to be taken very seriously to take them on a very long journey for their whole life. And this is one of our aims, to say, if you have ALL or whatever cancer in childhood, it's a long life story. It does not mean that you have to put it on a plate. No, it's one thing, reality in your life, but they have to be aware there are a lot of, they have to face their long-term, their late effects, and there are many of them. So this is the pillar of survivorship. And then we have, of course, a lot of things to do on EU affairs, long-term sustainability, like all other patient organizations. So this is actually everything, the most important thing about CCI Europe. If there are any questions, please write it into the chat or ask it to Samantha after, and then we can answer it by mail. I will show you now a 10 minutes video about ALL in children and teens, because it's so well explained that I think they are much better than I would explain you, and it's not so dry. It's made, I think, very nice. So, and it's, of course, it is different than adult ALL. So that's why I think, listen, look, if there are any questions after, we can talk about this. I will start the video yet.
Leukemia in children and teens. The human body. The body is made up of many billions of cells, and when they are grouped together, they form organs like the heart and lungs. Each cell has a job to do in the body. For example, one type of cell may help the body fight infections or to carry oxygen in the blood. Cells grow, divide to form new cells, then die. What happens when someone has leukemia? In some people, certain cells will start to act differently and become unhealthy. Unlike healthy cells, these unhealthy cells will not multiply or die in the normal way. When this happens, we find disease cells called cancer cells in the body. These cancer cells grow more quickly than healthy ones. That is how cancer forms. Leukemia is a form of blood cancer. It develops when cancer cells build up in someone's bone marrow and blood. Bone marrow is found at the center of bones where blood cells are made. There are two types of leukemia in children and teens: acute lymphoblastic leukemia, also called ALL, and acute myeloid leukemia, also called AML. Both acute lymphoblastic leukemia and acute myeloid leukemia are cancers that grow really fast if they're not treated right away after they're found. The symptoms of leukemia. When there are many cancer cells in the body, there are not enough healthy cells to do their job properly. That is when signs of leukemia start to show. Symptoms for ALL and AML are different from one person to the other. Most of these signs are often like signs that we see with less serious diseases. Here are some examples. Body aches, for example, in the arms, legs, knees, or back. Unexplained bruising, bruises suddenly appearing on the body. Pale skin, tiny red spots under the skin called petechiae, mild fever that doesn't go away, weight loss, a lot of bleeding from minor cuts, and feeling tired, a lack of energy, and shortness of breath during normal physical activity. Diagnosing leukemia. Since leukemia is a cancer of the blood and bone marrow, a blood and bone marrow sample is taken to help doctors find out what type of cells are diseased and where they are located. These tests make it possible to identify the type of disease. That is what we call a diagnosis. To confirm an ALL or AML diagnosis, a medical team will normally take blood samples, take a bone marrow sample, take a tiny sample of bone containing bone marrow cells. Once a leukemia diagnosis is made, it is important to start treatment as soon as possible. A special medical team will choose the best leukemia treatment. Children and their parents should discuss this treatment with their doctor. Asking questions is important for understanding the different treatments that are available and their effects. Treatments for both ALL and AML can be divided into 3 steps: induction treatment, consolidation treatment, maintenance treatment. Called induction treatment, this first step of chemotherapy uses powerful drugs. The induction treatment kills as many cancer cells as possible so that there is a normal amount of white cells, red cells, and platelets once again. The induction treatment usually lasts from 4 to 6 weeks. The patient will probably spend most of that time in the hospital. Sometimes the treatment must be given more than once before all the cancer cells are destroyed. The drugs used may have unwanted effects called side effects. Everyone reacts differently to treatments, and certain people may experience no side effects whatsoever. There are ways to reduce or stop some of these effects. Possible side effects include mouth sores, diarrhea, rashes, skin redness, dryness or itching, nausea, vomiting, fatigue, a higher risk of skin, nose, and mouth infections, and hair loss. But hair will grow back normally after the treatment. Losing hair is painless, and it may be a bit different when it grows back. For most patients, the side effects of treatments will lessen or go away completely once treatment ends. Once the induction treatment is over, the 2 other treatment steps begin. They are called consolidation treatment and maintenance treatment. Their purpose is to stop the cancer from coming back. The consolidation treatment is usually given in 4 to 6 month cycles. If chemotherapy is given intravenously, that is through the veins, the treatment takes place in the hospital, but the patient returns home once the treatment is complete. If the chemotherapy is to be taken orally, that is by mouth, the patient can stay home during the treatment. The maintenance treatment often involves drugs to be taken orally at home. For children and teens, the maintenance treatment usually lasts between 2 and 3 years. Normally, during this time, patients can lead a normal life and return to school. But extra care must be taken since they have a slightly higher risk of catching an infection such as a cold. Leukemia in children. In Canada, some 300 children are diagnosed with leukemia each year, which represents 1/3 of cancers in children from the ages of 0 to 14 in the country. Leukemia is the most common type of cancer in children 0 to 14. Among children with leukemia, 3 out of 4 have ALL. ALL affects more boys than girls. AML is less common and usually affects more girls than boys. Leukemia is a serious disease, but over the past 20 years, more children are surviving this disease. After the right treatment, the majority of children with leukemia are cured. Leukemia in teens. Among teens and young adults 15 to 19 years of age, 400 cases of cancer are diagnosed each year in Canada, affecting more boys than girls. Among teens diagnosed with cancers each year, 12% are cases of leukemia. Young people with leukemia will most likely have to undergo long periods of treatment. However, most of them can hope to lead a normal and active life. Here are a few facts about leukemia. A leukemia diagnosis causes many strong emotions, and that is completely normal. Sadness, fear, and anger are some of the feelings that may be experienced during those difficult times. People who have leukemia and their family will also have many questions about the disease. Here are a few answers that should help you understand leukemia better. Leukemia is not an inherited disease. In other words, parents do not pass it on to their children through their genes. It is rare that an affected child's siblings will also develop a pediatric cancer. Leukemia is not contagious. You cannot catch leukemia by being around someone who has the disease. We don't know what causes leukemia, so we cannot stop it from happening yet. Children and teens with a blood cancer are in no way responsible for getting their disease. Being sick is no fault of theirs. Leukemia is a serious disease that can cause death. But with the right treatments, the majority of young people will survive, return to school, go to university, work, and lead full and active lives. Even when properly treated, leukemia can come back. This is what is called a relapse. Fortunately, relapses are rare in children and teens with leukemia. During the first phase of leukemia treatment, it is possible that a young person will need to stop school for a while. For some patients, it may be possible to be schooled at home or in the hospital during that time. As soon as their health allows, they can go back to school and lead a normal life with their friends. Teams of researchers from all over the world are looking for better treatments with fewer side effects. The families of children and teens who receive a leukemia diagnosis can count on healthcare professionals who will support them in their journey towards a cure. Thanks to this research, most children and teens affected by leukemia today are cured.
So, yeah. Okay. So it is, we have chosen this because of, it explains in a very nice way what's about leukemia and the most important facts. And in Europe, for instance, we do have under 14 about 2,000 newly diagnosed ALL patients every year. So, but and what we want also to show is in childhood cancer, what you try when a child gets diagnosed. And one thing is that we really try to educate them very, very early. We show them videos, books. We take them on a journey, but I will show it to you afterwards, because it's not something what is very easy to understand. So that's why we try to use movies, of course, in different languages, that the child really gets to understand what happens, why they are sick, and why they're really sick when they come to the hospital. I will continue with the slides and will show you. Yeah. What I wanted to show to you is, because we are now starting a project together with Alan, that we really want to change our habit towards the children, because they I have a slide a little bit afterwards to say it is not so. Sometimes the hospital is patronizing, and you know that parents are very well explained. It's very well explained to parents, but because the child is very small, we forget sometimes to take them on this journey. As I said, we try to do it with books and videos, but on their journey, it's really sometimes we think they have understood everything, but we did studies to find out 10 years later and they don't remember anything. If they have been 6 or 7 and they get an ALL, if you ask them what happened or did you understand what was going on in this time, they don't know. So there has to be something different in our way to communicate with little children or even young people. They really do understand better. And what I wanted to show is this is one of the protocols what we use in childhood cancer, in ALL. And then this is given to parents. For instance, they hand it over on the first or second day and say, okay, this is a protocol. And I mean, who does understand that? No one. So this is always a picture we use. And when I was still a nurse working on a pediatric clinic, we always said at this time already, could we please use something different to explain to children how this journey, what this journey really means? And why I try to explain this in a little bit more, we try to make a project together with Alan, I already said, and this is called the Polaris Project. There was a mother in Israel, and I think it's 1.5 years ago. She is a graphic designer and working for public transportation system. So she understands, she's very logical, and her daughter got ALL. And then she said, so, I mean, what they gave it to me, this protocol, is this really serious? Should I now understand what they really think it's all about, what it has to be done in the first and second, third week? So this is why she tried to make a project together with one doctor, one parent, one doctor, and she did it really very well. I show you now what the project is all about and how you can explain in a completely different way what this really complicated treatment with so many late effects are in children this means. You see it here, it's a little bit too small, but I will show it a little bit bigger on the next slide. When you see this is really drawn by this mother. Her name is, I have to mention her because she's so specific. She's Soha Shalev, and she did it in a way where parents, relatives, carers, children really can understand. For me, it was when I saw it the first time, she presented this project on a conference 1.5 years ago, and she got standing ovations from everyone. I mean, the doctors were a little bit upset. They said, "What? You did never understand our protocols? I mean, what this is all about?" So she really tried to make this happen but she was, in the end, she was standing there and she said, you know what my wish would be? That all patients, it doesn't matter which age, need to be well educated and to understand the whole procedure from the beginning. Sometimes you're not ready in the beginning to understand everything, but it's completely different if you get a paper like this or like this, than what I have shown in the first slide. So this is a little bit too much to explain, but how she did that, and you know, I mean, she did it for her own child, and then she found out that so many parents were asking for that, and she showed it, I think only for the academia, as for the healthcare professionals, and they were already so excited, and they came back to Austria. They told me, can you please make this happen, that we have this lady from Israel again on a conference, and we did that. And that's why now this project is starting. It's supported by a pharmaceutical industry, but not led by them. So they give the money and we can develop this. So I think this is something very nice to have. And it's for ALL at the moment, for all existing ALL protocols in children, but also for teenagers and young adults. So and this is something what we have to work on together with Alan for the next 2 years. But then she's also willing to do this for other diagnoses. So I think this is a very good, very nice project. We only have to find the sponsors. Yes, but what works well? As I mentioned, what works well, or what does, I mean, the list could be very long, but I tried to be very brief and to say, okay, what it really means to say, to give an applause to the Children's Hospital, I have to say. Children's Hospital are really very well prepared for having all these very sick children, and almost more than 90% are surviving. And as I already mentioned, we have a very, very good psychosocial team in almost in the rich countries, I have to say, not in the Lear countries or in the eastern part of Europe, for instance, has to be developed, but we work on this, that the hospital, that those people who are responsible for the hospitals or the healthcare, no, the health system, we have to say, they have to understand that there has to be done a lot, because it's always the whole family who is, it's not different. I mean, of course, it's different when you have it in a very young age, because you're dependent on everyone, on the parents and on the health system. But the whole system is always affected, even you're an adult. And we explain it very well with the movies and the books, and they get everything for free. And we also deliver this to countries where they cannot afford. So what CCI Europe is all about is always we care, we share. Does not matter where you come from. This is something what harms all of us, and all children should have the same chances to survive. What is not the case at the moment, of course. What is also very important for us, that we have in many, many countries a program for siblings and for grandparents even. Yeah, it's a little bit like, because the siblings, what we have found out, France was very advanced in that, to look at the siblings, that we really have to really be, when I say the children that they get diagnosed with a cancer, they are sometimes treated as a little bit too much. The whole system is over them. We say they are under an umbrella and they never ever can get out of there. So we have to learn to say, yes, you had that, but now your life is going on, as we showed in the movie. It's not good if we say you had cancer and you get everything, because this is a little bit, when I was a young nurse, everything was around this sick kid, but the siblings were forgotten, and they have a lot of problems. We have a lot of mental health problems in siblings. We did a lot of studies there to see what we have to do as parents, patient organization, not really focusing on the whole family system, because we always say they are forgotten children. And it's a little bit for their whole life, I would say. And only that you can feel how we work as CCI Europe. My best colleague, Anita, what you have seen her on the picture, the only employee, she's a sibling. And I'm allowed to say that because her sister had ALL in Bosnia and Herzegovina. She survived. She's not a healthy survivor, but she survived, and she's doing well. But Anela, as a sibling, she has a lot of symptoms, and she started early on to show these symptoms, but no one had the power and the knowledge to see, aha, this sibling is suffering too. We have to take care about that. And it, of course, Bosnia and Herzegovina was at this time when her sister was diagnosed, it was, I think it was 7, 8 years after the war. So it was at least a double problem in countries where we always have to see what is also the historical background from a family when we talk about people. Also, cross-border healthcare is an issue for all of us. If it comes to CAR T-cell treatment, you will never get that in smaller countries or not so wealthy countries. So we have to take care about where they come from and also thinking about their cultural background. What needs to be improved is where we are not so good at this, that we know that they are separated for a very long time from their peers. There should not be something specific, but in some countries we have school programs. If the child can go back to the school, we come with them and we explain. Nowadays it's easier with Zoom. We can go there, we can educate the whole class. We can really try to make them aware that there was a serious problem, but now the child is healthy and they should take care but they should take this child normal as much as possible. Because one thing we know also from research is survivors of childhood cancer, their main wish is, please treat us as normal as possible. Because as you can imagine, it is a little bit a tricky part. You can make a lot of money with children and cancer. It's a very wealthy NGO. And I don't want to speak against my own organization, but it is something what we have to be aware, that we don't take childhood cancer survivors as, how to say that, testimonials. We don't want to make them as testimonials. We want to speak, they should speak up on themselves. They should say what they think they have to say, what they really want, that we focus on their late effects and on their long-term follow-up care. And this should be proper and not putting them on a plate or on a video to say, I survived cancer and everything was nice and I'm a hero. They always say, we are not heroes, we had childhood cancer. And it's not something what we were asking for, but we have to live with that. So this is also something what we have to learn from patients with childhood cancer, that they don't want to be something special. What we also miss in childhood cancer and in ALL specific, because the children are so young, we don't ask them for their own feelings. Prose doesn't really work. It would work if we have the right measurements, if we have the right tools, because children are very welcome to tell you every day how they feel. But we don't do that because we listen more to parents and the healthcare professionals still than to the patients themselves. So this has to be really improved. But this is a cultural change in the hospitals, because as you can imagine, as a pediatric nurse, I'm as paternalistic as all others. So we always thought we know it better. And we ask them with the smileys and so ever, but it is not enough to really ask them, because they would tell us 4 years, 5 years, there is already a good age. So this is something what we have to take more into account. And as I already mentioned, the long-term follow-up care and the late effects. I will show you one of these late effect slides. It's more or less one of my, this is one of my last ones, because if you have ALL or AML in childhood cancer, the survival rate is very, very good. And the protocols are working very well because it's worldwide. We use almost, in many parts of the world, we use protocols that are similar, or if some areas of the world do something different, they inform always the others. So there are study groups, they really work very, very well together. They really have in mind survival rates, but what they don't have in mind are the late effects. And why I mention it so serious, because this is also what I had to learn, because we were focusing on survival, of course. This is something what, when you have a child in front of you, you think, why you ask for fertility issues when you are 12 or whatever. So this is what we are not aware of. So, and what we have to say also is, we use in children with cancer, and specific also in ALL, all drugs off label. This means we use drugs, they are proven in adults, but not in children. And of course it's proven because we use it now for 40 years and it works very well, but it's very, very harmful. It's so harmful that they get so many late effects, that their heart can be a problem, that the neurological disorders we do have. So the endocrine system is very affected. So we know that one of the things we have to focus is to reduce this therapy, this kind of therapies. This is one thing why we are focusing also very optimistic to CAR T cells, because even we don't know yet what the late effects are, but what we can see now, that the late effects are less than if you use a common treatment. So this is one of the things we are really also are very interested to be part of big platforms, mean big data platforms, to collect all these results, what we have from all the studies we did in the last 30 years, to look if we can really reduce some drugs and in dosage, because the dosage is sometimes a problem. And fatigue, for instance, I mean, I know so many survivors, ALL survivors, they were also not educated when they are finishing their treatments, after their, all this what you have seen on the movie, after 3 years, most of the time they are cured after 5 years. We say, okay, now you are cured, and now the chance of a relapse is not as, yeah, it's there, but it's not, cannot happen so easily. But they are not explained well, even not in the wealthy countries. The Netherlands is a little bit different, and France is a little bit different. The UK is doing very well, but all other European countries lousy in explaining them. You know, you have to come back. They tell them you have to come back once a year, but they don't explain them very well why, and why they have to have a long-term or a lifelong care. So this is something where we have to improve a lot, to educate them better, because they came back on a national level, for instance, where I worked as for a parent survivors organization. They came back with a lot of, they were already discharged 10 years later, they were adults, they were 30 years old, and they didn't know what is going on with them. They couldn't concentrate. So quality of life is a big issue for childhood cancer survivors. A lot of studies are out there, but and I have to say, for instance, I'm coming from a small country, Austria, the survivors from childhood cancer, they did a very great job to educate the healthcare professional, to tell them, yes, you were the heroes too, that we survived, but you didn't do this, and this. Not in a bad way, but they really made them aware that they want to know everything. everything what their parents have signed, what they have to live with, where all this latent fact comes from, and not entering a hospital and getting to know that the doctors say, I know how you feel, or something like this. So what I wanted to say with this, the transition from having childhood cancer, an ALL, whatever, and 10 years later, then you're 18, or you get ALL with 16 and you are already out of this age with 18, because then you're not a child and this transition does not work that good what it should be. So the transition from pediatric to adult, and this is why I am very, very happy that we start on more on a European level than on a local level, I have to say, to work together with patient organizations. They are focusing on adults because we have different issues, but we have to make people aware to know, there is a patient organizations where you can go if you're an adult, if you get a relapse, or if you get a second leukemia, whatever, because they have a higher risk to get a second cancer. When you get a childhood cancer, you always have a higher risk to get a second one. So this is something where I am very happy about this, and this is something where we have to educate our patients better. Last but not least, CAR T cells are a big hope for us, I would say. I don't want to say much about it because it's very early, as a little bit in adults. I don't know many patients who got CAR T cells now, because in all European countries, it's a little bit different. Some start, for instance, in the Netherlands, there is now, children get it after the first relapse, high risk relapse, and before they get a stem cell. But for instance, in Austria, they do a stem cell transplant first, and if it doesn't work, they get CAR T cells. So this is why we say, as a patient organization, can you please include us in this discussion, because we have to go back to our community, means patients, parents, to explain what we don't want. It's a very rare disease. It's as I said, it's 2,000 in children, it's ALL in Europe. It's not a lot, but that's why we have to make our community aware, and more also the other countries, they are not so wealthy to say they have to have the same rights to get a treatment if it shows that it could be given earlier without so many late effects. Maybe we don't know that much for now, but this is more the things we have to concentrate on. So that's why we try to be in advisory reports for CAR T cells in children, but it also was very interesting for me to listen to the first presenter. What does this mean for the adult ALL patients? So I think, this is the CAR T cells now. They found there's one big company, they call this karate cells. So the T cells, so karate is one of the sports where you have to fight for something, but not in a bad way. So this is also a very funny thing. And they make a very nice movie, but it's in German. That is why I don't want it to show it to you. But there is already material out there to explain it to children when they get CAR T cells. Yes, and for us as patient organizations, patient representatives, patient advocates, whoever, I think for me, what I really learned in the last years, also for big data, to collect everything that really survivors want to put their data in there, to find out earlier, better, faster, and to collaborate on all levels. Also the pediatric world, I would say the whole world, not only the healthcare professionals, but pediatric was always very outside. They were the pediatric world and they were the adult world. What we really have to learn to collaborate and to learn from each other, and that this transition is possible and the best for the children who had already a disease in their childhood. So this is a message or a wish or something what is a vision. No, it's actually something what we already work on. And yeah, and thank you very much. It was not very technical, but if you have any questions about details, whatever, you can contact us or me, and that yes, wherever you want to do, I'm there to answer your questions. Yeah, it was not a full hour, but I think it's late and maybe you have questions. I don't know, Samantha, is there any?
Nope, not that I can see. So I think it was quite clear, and it gave us a good perspective on the child perspective that we don't have, for example, us with Alan. So that was very insightful. Thanks a lot for being here with us.
Thank you very much for giving me the chance to talk about the little children and their needs, or the young ones and their needs. Yeah.
No, that was great. So yeah, so I think we can free people and let them enjoy the day or the evening. And again, as we mentioned before, if there are any questions, you can email us. So you have my email, I can forward to Anita. If there's questions on the ALL session that we had before, you can also do that. Everything is going to be shared on Facebook and on the Alan website, so you can go back to the recordings, you can go back to the slides. And yeah, and I think that's it for now. We have, so next Tuesday we'll have the focus on AML, and Tuesday after it's going to be on APL. It's going to be a deep dive in APL. So if you want to join, you also have the link where you can register on the Alan website. And so we thank you all for being here with us, and take care, and see you maybe next week. Bye-bye.
Thank you. Bye-bye. Bye, Samantha. Have a nice
Bye,
evening.
Anita. You too. Thanks.